In this video, we'll discuss about the various middle third fractures. So starting with the LeFort fractures first. So LeFort I, which is also known as the low level or Guerin type of the fracture. Why? I'll be telling you why. So first of all, let's see the direction of the fracture line. So first of all, it extends from the nasal septum to the lateral pyriform rims, traveling horizontally above the apex of the teeth, then runs just below the zygomatic buttress and then crosses the lower third of the pterygoid laminae. So the last part, lower third of the pterygoid laminae, is a characteristic feature again, and it is asked in exams, the pterygoid laminae, which level the LeFort I fractures it. So it will be, of course, the lower third. Then the direction of fracture line is horizontal, and that's why it is also known as the horizontal fracture of the maxilla. The lowest level fracture of all the three types of fracture, and hence we have given the name the low level LeFort I fractures or low level fractures. Then fracture line basically passes from the zygomatico-maxillary buttress. That's why because it is passing just from this, so the subzygomatic fracture can be a name which can be given to these. Then Guerin's sign. Now that's a sign of ecchymosis or the hematoma and can be seen in the greater palatine foramen area on the palate. So this sign is also known as Guerin's sign, and it is present in LeFort I type of fracture, and that's why it is also known as Guerin fractures. Then we have gross mobility of maxilla can be seen in such type of fractures. So we have a term for this known as the floating fracture, because there is a dissociation of the bilateral fractures of the palate and maxilla from the rest of the skeleton. So that's why it is also known as the floating fracture. Now let's see the clinical features of LeFort I fractures. So if you try to tap on the tooth, you will hear or you will feel a cracked pot sound. Then you can see the gross mobility of the maxilla, that's why it is known as the floating fracture. You can appreciate step defect, tenderness and ecchymosis. Ecchymosis is generally seen in the relation of maxillary anterior and mainly in the zygomatico-buttress area. Then Guerin's sign can be there. Guerin's sign is nothing but it is the involvement of the greater palatine foramen. So you can see the ecchymosis or the bruises in the area of greater palatine fossa. Then mobility of the maxilla at low level in relation to fracture line can be seen. So you have to remember that it has to be at low level in relation to fracture line. Then you can see the epistaxis, but it may be there or might not be there. CSF Rhinorrhea or orbital injury are rare, but they can be there sometimes. So as we can appreciate in the clinical features here in the figure also, that the slight swelling of upper lip can be appreciated in LeFort I fractures. Then we'll try to see the ecchymosis. So in the buccal segment and beneath the east zygomatic arch, there may be presence or the ecchymosis is generally present. Then when you try to check the occlusion, so occlusion is disturbed with variable amount of mobility in the tooth bearing segment. Now sometimes the mouth may remain open, as we can see in the figure here. Sometimes the mouth may remain open because of the increased vertical dimensions of the bite due to the fractured segment having dropped down. So we can appreciate here the fractured segment has dropped down and that has increased the bite, and that's interfering with closing of the mouth. So that's the reason sometimes the mouth may remain open. Then percussion of the upper teeth. When we try to percuss the upper teeth, then this will give a typical cracked pot sound in LeFort I type of fractures. Then sometimes the fracture are felt only by grasping the maxillary teeth. So here we can see the hand is grasping the maxillary teeth. So only by grasping the maxillary teeth the fracture can be found, and applying slight but firm movement has to be there, and the grating sound may be felt. So you'll be able to feel a grating sound if you try to firmly apply the pressure. Now we have the LeFort II fractures, which are also known as the pyramidal fractures and the subzygomatic fracture. So why do we call it pyramidal fracture? Because of the shape of the fracture line giving a pyramidal shape. So the pyramidal shape of the fractured segment is the reason why we call it the pyramidal fracture. And why we call it subzygomatic? Because the fracture line runs below the buttress. Which buttress? Zygomatic buttress, and that's why it is also known as the subzygomatic fracture. Now certain clinical features which are important for the exam point of view. The first feature we have is the redness of sclera on the medial portion. Remember, it is on medial portion, and this is also known as the subconjunctival hemorrhage. So subconjunctival hemorrhage can be seen in LeFort I, LeFort II. Then we have ecchymosis all around eye or orbit. So this is also known as the circumorbital hemorrhage. Then CSF Rhinorrhea can be there and cannot be there. Pain, tenderness will of course be there because there is fracture. Then the step deformity at the buttress area can be palpated. Now gross swelling of face will be there. That's why it gives a look of moon face to the patient. So there is a question in exam, many times it is asked that reason of moon face. So that's the where do you find the moon face? That's answer will be LeFort II. Then mobility of the fracture segment at nasal bridge and infraorbital margins will be there. Now let's see certain illustrative figures, and that will be explaining the symptoms of the LeFort II fractures better. So that will help us, the picture memory will help us to remember these for longer duration of time. So the first picture here, we can see that there is a circumorbital ecchymosis. So bilateral circumorbital ecchymosis can be seen, and it is associated with rapid swelling of the eyelids, making their examination difficult. The second thing we see in the LeFort II fractures is subconjunctival ecchymosis or subconjunctival hemorrhage. Generally it is seen on the medial side, but again generally it is associated with the fracture side, but pattern can be variable, but we have seen it more on the medial side. Then now the third symptom can be the enophthalamus. As we can see here, the original position of the eyeball is this. Due to the fracture of the infraorbital wall, herniation of fat is inside this fractured segment, and that changes the position of eyeball after the trauma. So again, due to increase in the size of the orbit, either due to herniation of its content or because of separation of fractured bone, there can be enophthalamus, and this enophthalamus is basically the inward movement of the eye. So we can see the arrows here, the eye has moved towards the inner side. Then the fourth symptom or the clinical feature, there is a development of gross edema. As we can see, the patient before trauma and after the gross edema, the face has become moon-like, and that's why there is an appearance known as moon face appearance associated with LeFort II fractures. Now as we can see here, there is a fracture of the orbit. So there is damage to the orbit, therefore vision and eye movement should be tested as soon as possible. And we can see that there can be chances of diplopia, and diplopia is usually present and ocular movements may be limited. So generally the level of the eye, normally it should be higher, but due to the fracture and level of eye due to displacement of eyeball has gone down, and that may be the reason of the diplopia. Then we have the increased intercanthal distance. So we can see the intercanthal distance has increased here, and that is due to the fracture of nasal bone. The fracture of the nasal bone will cause the increase in intercanthal distance. Now in LeFort II fracture, if fracture of the cribriform plate is there, and of course the fracture of the nasal septum or nasal bone will be there, then there are chances of the rhinorrhea. So again, if fracture involves cribriform plate, there will be cerebrospinal rhinorrhea. Then we can see in the next figure, due to the fracture of the nasal bone, there will be nasal bleeding also. Then again, tapping of the tooth can give the cracked pot sound. So this is an illustrative image just to tell you the cracked pot sound. Then we have occasionally there may be a dish face deformity. This particular type is the dish face deformity in which the face becomes concave after trauma, and pre-trauma it was convex profile. So why is it so? How does it occur? Occasionally there may be a dish face deformity, as I have already discussed, and it is caused by lengthening of the nose due to the dropping of the middle third of the face away from the skull. So whenever there is a LeFort II type of fracture, which is a pyramidal fracture, so that may drop down from the skull, and that will increase the length of the face, and that will give a concave profile rather than convex profile, and that's known as the dish. Now as we can see here, it's a kind of examination in which holding the anterior teeth and moving them with one hand while placing the thumb and finger of the other hand over the nasal region. Now this will elicit movement over the bridge of the nose, and that confirms the LeFort II type of fracture. Then here also we can see that there is disocclusion of the molar teeth. So what happens if there is a posterior downward displacement of the maxilla? There will be posterior gagging, as the molars will become in premature contact, keeping the anterior portion of the mouth open, and that will lead to the open bite, we can say. So these are also the clinical features of LeFort type 2 fractures. There may be associated fracture of the palate, as we can see here, and generally it occurs in the midline. Blood clot and occasional hematoma can also be seen, and fetid smell is also a feature of the LeFort type 2 fractures. Now step deformity can be felt at the infraorbital margin, and there are chances of the, and of course not only chances but generally the infraorbital nerve is usually get injured. So fracture of the orbital floor we can appreciate in the figure. Infraorbital foramen is also fractured here, is there, and loss of sensation in the skin supplying the middle area of the face can be there. Now some differences that make the injuries of a LeFort III fracture more grievous from LeFort II are that the LeFort III is a high level fracture, so generally associated with other facial fractures like that of the frontal bone, or associated with LeFort II or I type, and that makes these injuries more grievous. So the LeFort III fractures are also known as high level fractures because of the high level of the fracture line. They are above the zygomatic buttress, that's why they are known as the supra-zygomatic fractures, craniofacial dysfunction, and they are called the transverse fractures. Now the passage of the fracture line, so the fracture line passes through the nasofrontal area across the medial, then posterior and lateral orbital walls, then the zygomatic arch, and through the upper portion, that is the upper 1/3 of the pterygoid plate. So this is the pathway of the fracture line for the LeFort III fractures. Now coming to the clinical features of the supra-zygomatic arch fracture or the LeFort III fractures. First, the edema of face, and that gives the appearance of panda facies. Then we have bilateral periorbital edema, bilateral circumorbital ecchymosis, and that gives the appearance of the raccoon's eye. Then we have bilateral subconjunctival hemorrhage, dish face deformity, depressed nose and flattening of the nose, and limited ocular movement, diplopia, that can also be associated with Enophthalamus due to the fracture of the base of the orbit. Then we have dystopia, hooding of eyes with anti-mangoloid slant. Then hematympanum, CSF Rhinorrhea. Mobility of the fracture segment at nasofrontal and frontozygomatic suture can be appreciated in the LeFort III type of the fractures. Then we have battle sign. What is battle sign? It is nothing but the ecchymosis at the mastoid process just below the ear and behind the ear. Now no intraoral feature present and no infraorbital depression is seen in such types of fractures. So this is our overview of the special clinical features that can be asked in exams. They generally ask the specific features like raccoon's eye or Enophthalamus or panda faces, all that they battle sign. So all these signs and symptoms they ask in exam, and we have to be clear with these. Now what is subconjunctival hemorrhage? Basically this is a bleeding behind the conjunctiva, so bleeding underneath the conjunctiva leads to the red colored eye in the medial portion mostly. And the important thing about this is it always remains bright red because air from outside keep it oxygenated, and diffusion of oxygen through the permeable bulbal conjunctiva keeps it oxygenated and it looks bright red. Then we have a term Epiphora. What is this? This is basically excessive tearing of the eyes. So how does it occur? Basically the nasolacrimal duct passes the secretion of the lacrimal gland into the nose. Okay, so there is a drainage of the lacrimal secretion into the nose through nasolacrimal duct. Now if there is a blockage of the nasolacrimal duct due to the infection or due to the obstruction of duct drainage, that may hamper the passage of that secretion into the nose, and that will lead to excessive tearing of the eyes, which is known as the Epiphora. Now what is the treatment for this? We should go for Dacry. The treatment is dacryocysto-rhinostomy, and we have to go for that. Now what is CSF Rhinorrhea? CSF Rhinorrhea basically is when CSF is leaking through the nose. So how does it possible? It is possible because of the fracture of the cribriform plate. So in cases of the LeFort II and LeFort III fractures, sometimes cribriform plate fractures, and that leads to the leaking of the CSF. Now what are the other conditions? Naso-orbito ethmoid fracture, cribriform plate fractures, frontal sinus fracture, and sphenoid sinus fracture. So these are the fractures that can lead to the leaking of CSF from nose. So there is a specific term known as the tram line pattern on face which is seen, and there is a halo sign or ring sign which is associated with CSF Rhinorrhea. So what is halo sign? Basically when you see this figure, you will be able to appreciate there is red blood in the center and the clear cerebrospinal fluid in the periphery. So that forms a halo. So the halo effect of leaking or the serosanguinous cerebrospinal fluid is seen in this filter paper. So as we can appreciate that halo sign, that is the clear drainage that separates from the bloody drainage, suggests that the presence of cerebrospinal fluid is there along with the blood, and that shows that CSF Rhinorrhea has taken place. Now orbital fracture. What is the basic feature of the orbital fracture? Generally when orbital fracture is there, the volume of the orbit increases. So the orbital volume increases due to the herniation of the orbital content. So where generally this herniation of the orbital content take place? It generally takes place through the ethmoid bone on the medial wall of the orbit. So what will happen once the content of the eyeball or the orbit is herniated, has gone into the medial wall of the orbit through ethmoid bone, then there will be increase in the volume of the orbit. Okay, and if you see this, you will be able to appreciate the tear drops which can be seen on the occipitomental view radiograph indicating the blowout fractures. So the infraorbital rim sometimes remains intact. The fracture may go unnoticed due to the presence of orbital, periorbital edema, hematoma, and the clinically intact infraorbital ridge. Sometimes you won't be able to find out the orbital fracture due to the clinically intact infraorbital ridge because it mostly remains intact. Then Enophthalamus can be seen with restriction of the extraocular muscle movement, and at times diplopia may also be present. So what is diplopia? Diplopia basically is the blurred or double vision which is experienced by the patient. Why it happens? Because of the change of the eyeball, right? When the volume of the orbit due to the orbital fractures increases, the axis of the eye or the position of the eye sometimes change, and that leads to the blurred or double vision. Now this diplopia is relatively common complication following the fractures of the zygomatic complex. When zygomatic complex fractures are there, the diplopia can be commonly seen. Now this diplopia can be of temporary or it can be of permanent nature following the injury. So there are two varieties of the diplopia. Now this diplopia can be of two types, that is the monocular diplopia and the binocular diplopia. So monocular diplopia, that means if the patient is trying to see, he is not able to see from single eye also. So even in the single eye there will be diplopia. So it is dangerous kind of diplopia, and it indicates that lens dislocation or the retinal detachment has occurred. Now this diplopia is present both while seeing with single or both the eyes. Now the binocular diplopia is present only when it is viewed from two eyes all together. Now what can be the causes for the diplopia? The most common cause is of course the edema and the hemorrhage that occurs in and around the extraocular muscles. Then the other reason can be the detachment of the muscles either from the insertion or from the origin. Then sometimes the entrapment of the muscle in the fracture segment can also lead to diplopia. Now most importantly or mostly the inferior rectus muscle is more involved than the inferior oblique. So how will you able to check the muscle entrapment in conjunctiva of the inferior fornix? So you'll be able to do that by using the force reduction test, and that can help to check the entire range of ocular motion. Now if normally if there is any diplopia, then the treatment required for the diplopia is just to wait and watch for the edema and hemorrhage, and you can wait for 1 to 2 weeks for the subsidation of the edema and hemorrhage, and after this subsides the diplopia will be resolved. If diplopia is not resolved in 14 days, then we can consider the surgical treatment. Now the positive force reduction test for the diagnosis that indicates the muscles entrapment, and you won't be able to get all the movements of the eyes due to the entrapment of the extraocular muscles. Then CT scan that gives the evidence of the more than 50% of the floor fractures. Then Enophthalamus, that is more than or equal to 3 mm. If it is there, then you have to go for the surgical treatment. And diplopia, if it is not resolved after 14 days, again you have to go for the surgical treatment. Now what is enophthalamus? So enophthalamus is nothing but inward sinking of the eye due to increase in the volume of the orbit. So why does that occur? Due to the blowout fractures. Whenever there is increase in the volume of the orbit, the volume increases, the eyes will sink inside, and that is known as the enophthalamus. Then blow in fractures, there is outside movement of the eyeball, that is known as the exophthalmos. So atrophy of fat is also sometimes the cause for the enophthalamus, but it is a less common cause. Most common cause is the blowout fractures. So we can appreciate here the enophthalamus, the eye has like already inwardly sinked, and we can see the eye has moved out. It is known as the exophthalmos. Now there is a term known as panfacial fracture. So what are panfacial fractures? The fractures which are involving all the three halves of the face, the upper, middle and the lower half, that is known as the panfacial fracture. So the treatment for that, so what should be the order of the treatment? So whenever there is a treatment requirement for the panfacial fractures, first we have to go for the palatal fractures treatment. So palatal fractures have to be reduced first or treated first, and this is the foremost answer to any question whenever they ask you what should be reduced first. So first option and first choice should be the palatal fracture treated or reduced first. Then we have the outer framework should be established, and then this is the second answer. If they give you in the MCQs, the outer framework should be established first, and any bone can be plated first, but LeFort I should be plated last. Now non-union and delayed union, there are two terminologies. Non-union is basically when the ends of the fractured segment becomes evernated, then the non-union will be seen. So when broken bone fails to heal, it is known as non-union. Now it takes more than 10 weeks to heal, and eburnation of the bone ends can be seen, as well as you can see the elephant foot deformity in the non-union edentulous mandible. So what is delayed union then? When a fracture takes longer time than usual to heal, and it can take approximately 5 weeks to heal, that type of union is known as the delayed union. Now we have internal suspension wiring for the suspension of the fractures of the middle third, and first this internal suspension wiring was described by Adam, and that's why it is known as Adams suspension wiring. Now there are two techniques. One is the direct suspension of the middle third fracture, and second can be the indirect suspension of the middle third fractures. Now coming to the meritus prefix, there are certain named wirings which are asked for the exams. So one is the circumzygomatic wiring. As the name itself indicates, this circumscribes the zygomatic arch. So suspension of the wiring will encircle around the intact zygomatic arch, and it is used for the LeFort I and LeFort II fractures. And this wiring was recommended by Lesney. So as we can see, there is a suspension wire which is encircling around the intact zygomatic arch. Then we have the zygomatic suspension. In this we'll be drilling certain holes within the zygomatic buttress itself and will be suspending the fractured segment. So it is also used for LeFort I and LeFort II types of the fractures. Then we have pyriform aperture or fossa wiring. So this is used for the LeFort I fractures, and infraorbital suspension is also used for LeFort I and LeFort II fractures. Then we have the frontolateral and frontocentral. Now this type of wiring is recommended for the LeFort III fracture, and that's why it's a unique wiring. And in this we'll be drilling certain hole. Hole is basically drilled 5 mm above the frontozygomatic suture. So this figure shows various positions, like for the pyriform aperture suspension wire, we'll be pulling hole in the pyriform apertures, then infraorbital suspension wire, then we have the frontal suspension wire and the circumzygomatic wire. So these are the different types of wiring which are used for middle third fractures. Now when there is a comminuted fracture of the mandible, so what we have to do, first we have to establish the occlusion by giving the IMF wiring. Step second should be reducing and fixing the bony segments to establish a mandibular framework. Once we get a approximate mandible framework, then we go for the step 3 and we try to construct the lower border of the mandible, that is known as lower border construction, and for this we use the load bearing plate to give strength to the mandible.